was when? Any idea what century that was in?
3000 BC.
Huh?
3000 BC.
3000 BC?
Probably
No.
after we started eating bread and stuff. Not
What?
when- Probably when we started eating
No.
bread. No.
1914 was the very first time in the New England Journal of Medicine somebody described appendicitis. They called it perityphlitis, which was a swelling of this thing right here. You have to remember that every single person who ever got appendicitis before 1914 died of it. Nobody ever survived appendicitis. Doing surgery on people was so dangerous back in those days that you wouldn't operate on them unless they were practically dying anyway. And appendicitis, since you didn't know what was really going on, and you didn't know what kind of operation it was going to take to do it, and the fact that there was only anesthesia available in about 3 cities in America, Baltimore, Philadelphia, and Boston, it took a long time for them to figure out and finally operate on enough people that had appendicitis. And you got to realize that they had to operate on it early when it was still appendicitis. Because if you wait 2 days, then this whole area of the abdomen turns to pus, and it's just nothing but peritonitis. You can't even tell where the infection started, you know, when you operate on it late. So it was really complex. And just think about how many of you have had appendectomies? How many of your kids have had appendectomies? Every one of those people would have been dead if they'd been born before 1914. Just think about that. That's only 102 years ago. Yeah.
So, just a quick question. So, I know that with an appendectomy, time is super important to get it done as quickly as possible.
Well,
So, what do you look for when a patient comes in to narrow it down to figure out what it is?
yeah, well, I would just say that appendicitis is one of the hardest diagnoses there is to make. There's not really any good x-rays for it, although with new modern CT scans and MRIs, which cost $3,000 or $4,000, that can help you a lot. But back in the day, in the 1990s even, you diagnosed appendicitis by talking to the patient. When did your pain start? Where was it? Generally it starts in the mid-abdomen as the appendix swells a little bit, and then gradually as it starts getting red and starts irritating the peritoneum over here along the side, then it sort of starts moving to the right lower quadrant. Do you have a fever? Have you had any chills? Any of those things? It's, you look for an elevated white count maybe, but that doesn't really help. You want to make sure they don't have a kidney infection, so you check that. If it's a female, you want to make sure they're not having a ruptured ectopic pregnancy or a ruptured ovarian cyst. Those are the things that are complicating it. These days, most of the time, what they'll do is they'll just laparoscope you. They'll put do incision this long, put a camera inside your tummy and look around. Then you can figure it out exactly. And so it's a lot easier. Things have changed a lot. Even in ultrasound helps a little bit. If it shows a lot of swelling around this area, occasionally you can see the appendix itself on the ultrasound. Nothing's very good, really. The best situation I ever had for diagnosing appendicitis was when I was on the ship out in the Mediterranean. Because these guys would all come in with a bellyache. I got a bellyache, doc, and you kind of wondered whether they really just didn't want to go to work that day. And you'd get their chief up there, their supervisor, and say, listen, chief, I want you to bring this sailor back to see me every 3 hours. I don't care if he says, I don't want to go to the sick bay. You bring him up to see me every 3 hours. And you just do consecutive examinations. And if it gets worse and the pain starts getting more obvious and they start doing a little rebound every time you push on their tummy, it hurts them real bad, then you made the diagnosis. Nothing else really helped. Sequential examinations are probably the best way to diagnose appendicitis. Did I see a hand up over there?
Oh, I was just asking, I have 3 incisions from my appendectomy, and I was just wondering why 3 instead of just 1.
From 3 little ones? Mm-hmm. Yeah, they put in a camera.
Okay.
And then they saw that there was a problem. Then they put in 2 more trocars to run the instruments through, to run the scissors and the clampers and the grabbers and all that stuff to take it out. So they actually did it through the laparoscope.
Okay.
Yeah. It takes 3 holes to do almost anything. Yeah, 4 for a gallbladder is not unusual. Yeah.
1, 2, the main one, and then 1 down by my belly button.
Belly button is where the camera went in, yeah.
Can you damage your appendix from physical contact, like being punched in, that area or something?
That would be pretty hard. I think if you got punched in the area down there, you'd be much more likely to rupture your cecum or your intestine or your kidney than your appendix, because it's so small it doesn't really fall prey to that.
The myth is that Harry Houdini had developing appendicitis, and he was known for like, oh, I could take it, he punched.
Yeah,
Someone was
yeah.
like, take this, Houdini, punched him when he wasn't ready for it, punched him in this side, it ruptured his appendix, and like 3 hours later he fell over dead.
Well,
Yeah.
probably it makes a good story, but probably didn't work quite that way. I
Probably
doubt
not,
the punch
but
did
that's
anything, but if he had
myth of it.
appendicitis, it was getting worse and he died of it, yeah.
In my place, I
kind
used
of
to
a
carry
fun myth,
the
You
water
know, like,
tank on the left side of my and then I carried that for a long time, and that caused me stomachache. Thinking that it's
I don't think it's anything inside the tummy, I think it's your muscles of your, yeah, from carrying it. Okay, let's talk about the colon a little bit more. It has a larger diameter and a thinner wall than the small intestine. It has these little pouches that hang off of the colon called haustra. I'll show you those on the picture. I don't think they really mount to much. They allow the colon to get bigger. Surprise, surprise. One thing about the colon is the colon does not have a consistent layer of longitudinal muscle. In other words, the longitudinal muscles do not go all the way around the colon. They break up into 3 parts. So instead of looking like this being your external layer of muscle, right? It breaks up into 3 pieces, and so all of the muscle is either here, or it's here, or it's here. And I'll show you a picture of the colon, that'll make sense to you. But yeah, those are called the tinea coli. They're the only parts of the colon that really have that 3rd layer of muscle. So that's whenever we sew the colon back together, we always sew it in a tinea, because you've got an extra layer of good stuff to put stitches into and hold it together. The serosa of the colon, the outside, has these little sacs of fat called fatty appendices or epiploic appendices. It's something that helps you identify the colon as being colon, but it doesn't really help you with anything else. I think we've talked enough about these things. The descending, the sigmoid colon. And let's just talk about the blood supply to the large intestine. The blood supply comes from the superior mesenteric artery. Remember the superior mesenteric artery up there? It comes off and supplies the whole small intestine, but it also supplies the whole right colon and most of the transverse colon, like that. The lower part of the rectum and the rest of this colon over here is supplied by another artery, which is called the well, if this is the SMA, what would you call this one? Why don't we call this the IMA? Superior mesenteric artery and the inferior mesenteric artery. The rectum is that last 15 centimeters or so that's straight. It's also for temporary storage of feces. It's not until feces start to move down into your rectum and your rectum gets stretched a little bit that you get the urge that you need to go to the bathroom. Okay? The anal canal is the very last portion down at the very bottom. It has some little things called anal columns. There's some muscles down there that keep the flies out, basically. They also hold some stuff in, but mostly they just, well, I'll talk about that in a minute. The anus is the opening. It has keratinized epidermis, so it's really turning into skin before it actually goes out. So it's not like the inner lining of your mouth, you know. But you only have to go up about that far until everything turns to columnar epithelium, right? It's only that last little bit that is the stratified squamous epithelium. We have two sphincters around our anus, the internal and the external, and they go around, and one of them is the external one, is the lowest one, and it's the one that is under your control. And you guys have all gotten the feeling like, oh man, I need to get to the bathroom, and you're kind of doing this, and you're trying to hold everything in. Well, that's because you can control the external anal sphincter, okay? But you cannot control the one that's really important. The one that's really important is the internal anal sphincter, and it's just up inside of that, and it stays closed all the time, because otherwise, if you didn't have this one, you'd mess your britches every single night when you go to sleep, right? But luckily, we have this internal anal sphincter, which is smooth muscle. It's not under our control, but yet it stays closed all the time in order to keep things in. So really, your internal anal sphincter is the one that does all the work for you. This external, this is the one my teachers would always tell me, the only purpose it has is to keep the flies out. Because it really, you know, you can control it, but I mean, how many people want to sit around all day long and all night long thinking to keep their external anal sphincter closed? They don't.
One keeps the thread in, one keeps the flies out.
Yep. So anyway, here's the picture that I've been trying to draw up there piece by piece. Notice these little, these are the Taenia coli, and I said the strips of muscle, there's only 3 of them. 1, and then 2, 3 back in here. These little appendices epiploica are little globs of fat that kind of hang off the outside of the colon. The haustra are these bulging things, like you see there. This is the ileocecal valve. The ileocecal valve controls the emptying of the ileum into the cecum. And that's important because this is just watery stuff up here, and you don't want it all dump into your cecum at one time. You want it to kind of gradually let it in so that as it makes its way around the colon here, you can absorb all that extra water out of it. Here's the SMA, superior mesenteric artery, coming down and supplying this much of the colon. This is the IMA, and it only provides blood to this part of the colon. And remember that the SMA also completely goes to the small intestine as well. So it's a pretty big blood vessel. The Katie Couric story.
And video.
And video. Yeah, we can watch Katie Couric getting her colonoscopy. Let me just tell the story that's associated with it. Katie Couric, you know her, she's a broadcaster on NBC, and she's had several shows. Really, she to me is the definition of perky. I don't know, Katie Couric just seems so perky to me. Well, she was married, and she had a couple of kids, and her husband kept complaining that he was passing blood in his stool. And he went to his doctor, and his doctor says, well, I know what you need. You need a flexible sigmoidoscopy. And a flexible sigmoidoscopy is you take a sigmoidoscope, which is about this long. It's flexible, so you can turn it and twist it. And it looks up into the colon about up to here. And the reason that was a useful thing was because every family doctor in America could do it. It didn't take any special training. And honestly, they wanted the money. And they didn't want to send their patients to the surgeons or the gastroenterologist who had the colonoscope, which is about this long, and could see all the way around the colon. And also, about 60% of all colon cancer occurs in that lower part of the colon. So they're thinking, oh, well, you know, we can pretty well screen the colon. Just check out the lower part. We won't miss many. Well, he had that, and it was okay, and so they said, well, don't worry about that bleeding. It's probably just from hemorrhoids. And, you know, he waited 9 months, and he came back, and they did the same damn thing for him. And finally, he came back about 6 months later, and he said, no, I want something else done. And so he had colonoscopy, and when they looked around over here, they found a big colon cancer in his cecum over here, and he died about 5 months later, I think, of disseminated colon cancer. So Katie Couric, being the news lady that she was, said we need to publicize colon and rectal cancer because it kills more people by far than breast cancer. Now, I bet lots of you ladies in here have already had your first mammogram, but I'll bet none of you have had your first colonoscopy yet. Well, you don't need to have a colonoscopy until you're 50, but when you're 50, you ought to have one. And just so you know, I've had 3 of them when I was 50. No, I've had 4. 50, 55, 60, and 65. And each time I've had a couple of little polyps removed inside my colon. Polyps are precancerous lesions. Once you take them off, nothing to worry about. They take about 5 to 10 years to become malignant. So if you're having polyps, you want to get a colonoscopy about every 5 years. If you have a totally normal colonoscopy, you don't need one but about every 10 years. But I've already had 4, and you know what? It's no big deal. I drink some stuff at night. I get up. I don't usually ever even get up at night. I get up in the morning, and man, everything comes out. You're pooping water after a little while. No cramps or anything like that. And then you go in, and they start an IV in you, and they give you some Demerol and Versed or some, and you don't remember anything about it. You sleep through the whole thing, and you wake up. Last time I had it, I woke up. I didn't even know it had started. I'm in the recovery room, and I said to the nurse there, I said, "When are we going to start?" And she said, "Oh, you're already done." And I'm like, cool. And I mean, that's really the way it is. Everybody has these terrible, I can't stand anybody putting a finger in my butt, much less putting a 6-foot-long tube up my butt, you know. So they don't want to do it. But let me tell you, it saves lives. And so many more people die of colon cancer than breast cancer, than almost all forms of cancer. It's really worth doing. And it never has cost me a single dime. I don't have the greatest insurance. I got Kaiser. I think I paid $20 for the copay for the whole thing. Anyway, yeah.
At what age does it become valuable to start going in for colonoscopies?
50, age 50.
Unless you have.
Unless you're passing blood, or you have
Crohn's or colitis.
Crohn's. If you have Crohn's disease, if you have ulcerative colitis, those are diseases that cause cancers to occur earlier. So they do start earlier. But mostly they're not looking for cancer, they're looking to see what the condition of the UC or the Crohn's is.
So
Yeah.
3 years ago.
Are we going to have a story here?
No, it's I mean it is. It's really
Is it
short.
going to be a good one?
It's a good one.
Okay.
So anyways, 3 years ago, my dad was supposed to have bladder surgery, but like he had, I forget, like his blood pressure was too high, so like he'd been putting off his colon. My dad was 63 at the time.
Sure.
Put off that colonoscopy, put off that colonoscopy, put it off. So anyways, they put off like the bladder surgery because of his blood pressure. So they're like, well, let's do your colonoscopy. And I'm like, you know, because he finally had his colonoscopy, they found his colon cancer in stage 1.
Yeah.
Because they found it, because like if they
It's
had
it's one of the most totally curable cancers if it's caught early. If you don't catch it early, it's one of the worst cured cancers. But but let me tell you, the day you know that this country has changed its mind and realized it's okay to get a colonoscopy is the day we have brown ribbons around the White House and we're celebrating Colon Cancer Week. It's really easy for everybody to put up pink ribbons and have Breast Cancer Week or breast cancer runs or breast cancer this or breast cancer that. But about 5 times more people die of colon cancer than do of breast cancer. But nobody wants to talk about it.
Well, because it's the butt. If people like
It's your butt. That's right. What's wrong with that? It's just,
everybody's got a butt.
Poop machine.
There's a book. Everybody poops.
yeah.
Right? And if you don't.
All right, let's get through with this. Anyway, here's the ileocecal valve. If you open up the cecum here, you see it. It's just a little round thing. Here's the rectum, the anus, and notice there are 2 muscles. The internal one, which is the one that really works all the time, and the external one, which is the one you can control voluntarily out there. What does the colon look like under the microscope? It's so obvious when you look at colon. Just remember that it doesn't really produce any enzymes. It does secrete a lot of mucus so that you can slide your stools on through there without hurting you, providing lubrication. It does have a lot of lymphoid nodules, kind of like the Peyer's patches. Remember that the longitudinal muscle is not found all the way around. It's only found in 3 bundles, like we talked about. So here you are looking at it. This is the surface out here. Notice there's big crypts that have lots of, and it's almost as many goblet cells as it is intestinal cells. See, look at this over here. There's more goblet cells than there are normal cells coming through there. Here's a lymphoid nodule over here, like a Peyer's patch. You don't have big villi, and you just have these little openings to these crypts down in here, and I'll leave it at that. Less than 10% of the nutrient absorption occurs in the laryngeal system. You don't really absorb any sugars or fats or proteins through the wall of your colon. You do pick up a few vitamins, like I talked about. Basically, the large intestine is preparing your feces for ejection. I like that term, ejection from the body. We reabsorb a lot of water. We reabsorb a lot of the bile salts that we poured in up at the bile duct, remember, way back upstream about 6 hours ago. I think that's it. That's all I want to say. The vitamins that are important are A, D, E, and K, right? A, D, E, and K. ADEC is the way I always remember it. And that's, those are also the vitamins that you can overdose on. So just because you go to Costco and just because you can buy a great big bottle of vitamins, they're not necessarily good for you. And those are the ones that will kill you, A, D, E, and K. All the rest of the vitamins that you can buy in mass quantities, you just eat them, you absorb them, and they go right out through your urine. You just pee them right out. We used to tell people who had kidney stones or that had bladder infections to take a lot of vitamin C. Another name for vitamin C is ascorbic acid. And they ate a whole bunch of vitamin C. It just passes right out in their urine. It makes their urine really acid, but that kills the bacteria, so it can help them fight the infection. That's about the only good I ever saw with any of that stuff. So don't waste your money. If you're going to take a vitamin, take a multivitamin once a day, and don't take 2 a day. You only need 1 a day. Yeah?
Is it because they're fat soluble?
Those are fat solubles, yes. And they work their way into your liver usually and fill up your liver with A, D, E, and K and can give you troubles. Here they are. Vitamin K is fat soluble, biotin.
Can you overdose on biotin?
I don't know.
I take it to make my nails grow.
Makes your nails grow? Does it work?
Yeah,
Oh God, it makes them turn blue too. God, they turn
Makes
blue.
your hair grow.
Makes your what?
Your hair grow.
Makes your hair grow.
Hair prenatal vitamins is a key part.
I've told you my hair story, haven't I?
Yes.
You
About
don't
washing
shampoo?
your hair?
Yeah.
Yeah, you told us that on the first day of
No, that was on chapter 5, the skin chapter.
You're right. It was on
I was sitting at the gym out at the Dalles one day, and there's this nurse who I'd worked with for years and years, and I'm sitting there shooting the fat with a bunch of guys, and we're all older. I was about 55 at the time, probably. And I said, you know, I never have used a bottle of shampoo in my whole life. And this nurse looks at me and says,
Ew.
"Ooh, are you kidding me? You haven't used shampoo?" I said, "No, I've never used any shampoo. I just use a bar of soap. And it works fine."
Here's
And
how
she
it wants
says,
to turn.
"Ooh," I mean, she probably used the $20 kind of shampoo and the $15 kind of conditioner. Because if you use shampoo and you get every bit of oil out of your hair, then you got to use conditioner to put the oil back in your hair. It's a total waste of money. Just use a bar of soap. And look, I go to my barber, and my barber says, "You've got the best head of hair I have ever seen."
incontinence.
But that's because you have short hair.
Yeah,
Short?
yeah,
You
that
don't
will not
color
work for
treat
long
it.
I
hair.
don't have color, I don't color treat it, that is
This
true.
doesn't work with just a bar of soap.
Well,
No, God,
Before
no.
color treating or not, this, I would have a dreadlock.
I'm
I'm
I'm just gonna tell you my own experience.
Yeah, short hair.
Yes, ma'am.
That's what people
Swap.
Yeah, everybody in the real world, excuse me, everybody except the first world people, all of us first world people, use all this crap, but we really don't need to. Anyway, let's keep going. I gotta get through this. Bacteria breakdown. Remember that bilirubin that came in along with the bile? If we break it down into urobilinogens and stercobilins. Now, those are chemical breakdown products of bilirubin, and the reason that they are important is because once we pour them out into our intestine, they go down the small intestine, they get broken down, and then we reabsorb them through the wall of our small intestine. Urobilinogens are reabsorbed back into the bloodstream, and then we pee them out, okay? And that is why our urine is yellow, okay? Because that's a breakdown product, that's urobilinogen, and urobilinogen is yellow, and it's a breakdown product of green bile. And so that's why your urine is green, and in addition to the urobilinogens, we also reabsorb some stercobilinogens, and that's what makes our poop brown. And your poop should be brown. And I would tell each of you, I try to give these health
Life lessons.
tips, yes. One of them is, you ought to take a look at your stools. You know, it doesn't cost anything. It's a simple test. Just look at them. They should always be about the right color. And if they're not, there's probably something either changed in your diet or there's something really wrong with you. If your stools ever get really black, that's usually blood. Because blood, especially if you bleed at the top end of your system, like from your stomach or from an ulcer in the duodenum, by the time that blood works its way all the way down, it's black. And so it just looks like black stools.
When I said my gallbladder issues, my stool was about as white as dried cement.
That's because you had a
And my
blockage
urine.
of your bile duct.
And
You
my
weren't getting
urine
any
was-
green stuff in.
Right, my urine was like
Yeah.
brown. It was so bad. I was so sick.
Okay, a couple other things here that happens in our colon. Our bacteria break down a lot of the stuff in the colon and creates ammonia. It also creates these two gases, indole and skatole, and hydrogen sulfide. Those are basically the gases that account for the odor of your stool, right there. Not really something scientific, but just so you know, that's really what's going on there. Flatus is a fancy name for farts or intestinal gas. Or flatulence, yes. Now, one thing you need to know about the colon, because it doesn't work quite like all the rest of the bowel. The rest of the bowel, remember we talked about this process that moves the food down the small bowel, and we called that peristalsis. Well, in the cecum, it's a little different than that, because we have another type of movement that occurs in the colon, and it's called the mass movement. And what that means is usually the movement in the colon is just really slow and sluggish and there's not much to it. But when you get ready to have a bowel movement and you've got a little stool in your rectum that's distended a little bit and your brain gets a signal like, I need to go to the toilet, you go to the toilet, you sit down, and then these movements occur called mass movements. And I bet that every one of you has had, if you add up the stools that are in the toilet, you could probably make, you know, something like this. Well, the only reason it made one that long was because it had a mass movement. It emptied all the way from the hepatic flexure. I mean, the whole transverse colon emptied, the descending colon, the sigmoid colon, and the rectum all emptied at once, which is common, and that's this thing called a mass movement, which isn't on that slide, but let's. I know it's here. Here it is, mass movements, And, you know, it's so funny as a physician and a surgeon, especially a guy who operated on a whole lot of colons, I would have people come in and say, hey, Mr. Jones, how you doing? He said, how you been? He'd say, fine. I'd taken a piece of his colon out maybe 2 years ago. And he said, well, my bowel movements have been pretty good. I said, oh, that's good. And I could care less, but nice to hear that. And he says, and here's my book.
Oh my gosh.
And he would give me a book that was like 400 pages long, describing every bowel movement he'd had for the last 2 years. Well, it was about 6 inches long, and there was another one that was about 5, and they were about this big around, and they were this color. We Americans have this big hang-up about our bowels. It's really out of control. So keep that in mind. Okay, you just keep them moving. That's all you got to do. I've already said this a couple times, but the reason we get the feeling that we got to go to the bathroom to have a bowel movement is because our rectal wall gets stretched a little bit, and that's what triggers this defecation reflex, and that starts a positive loop. And I'll show you the. You should read through this. I think I'll ask a question or two about this, so you know, because it's pretty interesting. Looks like this in your book. The whole thing starts right here in the rectum. The rectum gets distended a little bit. You send some messages all the way up here to your motor neurons up in your brain that says, hey, my rectum is stretching. And then it starts sending messages back, and it sends messages back to get your intestines moving a little bit, and this whole circle goes round and round, and then boom, in comes. And then you've got to relax your muscles down here. Remember, you can relax the external sphincter, but you have to let the internal sphincter relax on its own. So that's part of this reflex here of letting you have a bowel movement. That's called the defecation reflex. So you're gonna study on that a little bit, right? I think I've said all of that. Let's talk about nutrition a little bit. We have another chapter coming up next called metabolism. We'll get to that next week. But basically every time you eat a meal, you eat some carbos, you eat some proteins, lipids, water, electrolytes, and vitamins. It's in everything we eat. So those are the 6 things that you have to deal with. And every one of them is digested differently. I think that's the point. That's why we've been talking about this for the last 3 days of how we digest food. Most of these, water, electrolytes, and vitamins, they can usually just be absorbed right across the membranes. They don't usually, but some of them do require some special transport. What's that one that leads to pernicious anemia? It needs intrinsic factor, which is secreted by the stomach, and to absorb B12. And if you don't get B12 absorbed, then you develop this type of anemia called pernicious anemia. Okay, just wanted to remind you of that. I think I've said enough there. Our enzymes are secreted by a whole bunch of different places. We've talked about all of them. And they are designed just to break down the chemicals so that we can absorb them. The brush border enzymes are those ones that live right along the edges of the